First of all, I would like to thank you, everyone in the GE team, for giving me the privilege to present tonight in this very special event, in this very beautiful and extraordinary place. Thank you. I will start my presentation saying a few words how my ultrasound journey started. Back in 1997, I was working in a university hospital in Athens called Areteo Hospital, where back then, we're talking about 28 years, no one knew anything about breast ultrasound. So I had a patient that had a screening film, you can see here screen film mammography, and she had dense breast. Her mammogram was read as normal. She left our unit, and then a day after, the surgeon came in complaining that we had missed the cancer. I was very frustrated as a young, radiologist, and I had a great vision. I thought with mammography, everything could be seen. I was really sad because the lesion was palpable. We took that patient back in the ultrasound unit, and we performed a breast ultrasound, and we found the cancer. So I really learned my lesson, and since then I started performing breast ultrasound in every patient, in every woman that had dense breast. So my experience goes back with breast ultrasound over 28 years. So ever since, we have learned a lot. There are a lot of publications globally that have shown that women's breast varies in the stromal and epithelial component, and that one size does not fit all. So we have three different groups of women. We have the average. We have women that belong with average risk. We have women that have intermediate risk, and we have women that are having a higher risk. And which women have an intermediate risk? Actually, are those women that have extremely dense breast and also have heterogeneously dense breast. Also, those women that have personal history of breast cancer and their breasts are dense. So we have great challenges in these women with dense breast. And the challenges that we have is the story that I said in the beginning, that those women are having a great risk of having a cancer that will be missed by great radiologists with a lot of experience, because the cancer is just missed. It is not seen. So we have what is called the effect of, the sensitivity is lower. Also, these women have a greater risk of developing a breast cancer. They have 4 to 6 times higher risk. And many studies have shown that in women with dense breast, the size of tumors that are diagnosed are larger in size. They're grade 2 or 3 tumors. And in this slide, you can see the sensitivity, how much it is lower. In women with extremely dense breast, it goes down to 57 to 71%. It means from 100 cancers, almost 29 cancers might be missed because they're not seen. And here you can see how obvious the cancer is in women, in this woman with fatty breast. However, in this patient, the cancer is missed. So the solution is to change the pattern that we have in current screening programs, where they're based on women's age, and to progress, and to see the adoption of future screening programs under risk stratification. This will help women. This will help all of us to find cancers at an earlier stage. It will improve screening outcomes by reducing the mortality rate, and also it's going to reduce the interval cancer rate. There's a lot of work, fabulous work that has been done in the USA by Dr. Wendy Burke and also Joanne Puskin, the Dense Breast Info, a world-leading website about dense breast. They have achieved a lot. Look here, the entire map of the USA is highlighted in pink because there's a new FDA national requirement for density in every state that has been effective from from last September 2024. Also, there's a lot of work that has been done with the Find It Early Act. It is a federal bill introduced to help ensure all health insurance plans cover screening and also diagnostic breast imaging. What are we doing in Europe? Well, we're working a lot and we are improving also because we have launched the Dense Breast Info, where many countries are participating. It is a very comprehensive for density, a medical research website that gives a lot of information to healthcare providers about breast density. Later on, the DENSE trials came that showed that there is a great reduction in, we can see here in the interval cancer rate. It decreases by 50% if MRI is implemented every 2 to 4 years. Therefore, new screening guidelines came out by USOBI saying that in women that are aged between 50 to 70 years and have extremely dense breast, screening breast MRI should be performed every 2 to 4 years. And there are many other societies you can see here, besides USOBI, ACS, NCCN, ACR, that are also suggesting that supplemental screening is necessary, either MRI or possibly by USOBI, possibly ultrasound should be indicated in women that have heterogeneously and dense breast. However, MRI is an excellent, I would say, excellent imaging modality with very high sensitivity. However, you can see here from the ECRIN study and also the Dutch trial that the acceptance rate is quite low because many women have claustrophobia. Many other women have, they just avoid, they don't want to have IV contrast. Also, the NCCN guidelines suggest the whole breast ultrasound should be done if contrast imaging or any other functional imaging is not available or accessible. And a very interesting article was just recently published by Magda Macron that also adopts the USOBI and highlights the USOBI guidelines, suggesting that in women that have heterogeneously and also extremely dense breast, either MRI or breast ultrasound should be performed. So I'm working, as Alexandra introduced me in the beginning, at Athina Medical, where we have, our mission is actually patient-centered. We are working only for the patient, only for the women that comes, and our mission, our leadership and quality improvement drivens are aligned to patient-centered goals. Care is collaborative and personalized according to patient needs. We perform the right test at the right time, at the right person. We see approximately over 10,000 women annually. This is the one-stop breast clinic that we developed about 3 years ago. Over 90% of our patients are self-referred, not only from Greece, but from the Middle East, from Europe, and also from the USA. They come back, they're Greek ladies that come back to see their family and friends, and they come also in to have their medical checkup. Over 70% are screening and 30% are diagnostic patients. So how does the development of the one-stop breast clinic works? We use AI for density assessment, also for risk identification, and then according to women's pattern breast composition, then we supplement automated breast ultrasound, ABUS initially, and then we use DBD, we use combo, also 2D mammography and MLO view. If we have women at high risk, we use MRI at the same day, but biopsies performed in all BI-RADS 4 and 5 lesions. We perform the biopsies the same day. We have a weekly board meeting. We do the staging with CT scan. We provide our patients, if they wish, they have genetic counseling, psychological support, and also nutritional counseling. And our multidisciplinary team is supported by all relevant subspecialties in breast care. We discuss the results directly with our patient, and also there are further treatment options, what is needed, and to prepare the treatment plan. This is done, it's amazing, because because before we had started the one-stop breast clinic, we actually in Athens needed about 20 to 25 days to start from diagnosis to staging. This has been reduced only to 2 days. So this is amazing, especially for women that come in from abroad or from the islands and travel, have nowhere to stay. They have family back home, so they need to go as fast as possible. So as I started with my talk, I do have a lot of experience with breast ultrasound. This is a paper that we published with Dr. Wendy Berg. We evaluated over 400,000 ultrasound exams, and we found an incremental breast cancer detection of 3 cancers per 1,000 women. What is important with breast ultrasound and what is amazing, it is that it's very accessible. It is there for every radiologist. Everybody cannot have the same tools, so we have to use the best that we are best to offer to our patients. So it is accessible, it is relatively inexpensive, and unlike mammography, it is not affected by breast density. No ionizing radiation is required, neither IV contrast. However, we have had some challenges with handheld breast ultrasound, and I'm sure all of you familiar. It is an operator-dependent technique. There is reduced reproducibility of images with a small field of view, and the images are static, especially in the USA, where ultrasound is performed in most centers by technologists. The radiologist is obliged to just read static images, not the entire examination. The examination is time-consuming. We also have there's lack of manpower globally at this time. So innovative techniques are helping us to provide our patients comfort and efficient experience. And this is how our ABUS room looks like. This is one of our techs. So the advantages of automated breast ultrasound, it is the fact that it's a standardized and reproducible technique. It gives us a large field of view, global visualization of the breast. It is not affected, just similar to handheld breast ultrasound by breast density. We have precise location, the information of any suspicious lesion, you automatically get exact location and distance from the skin and from the nipple. We have, you can see here the reverse curve transducer. It is also live here for you. So the scan is done automatically, starting inferiorly from the inferior part of the breast, driving superiorly. And what is the great advantage of this technique is that once the scan is obtained from the transverse image, it is reconstructed with a special software. So therefore we have, here you can see the coronal and also the sagittal plane. Therefore, whenever we have any suspicious lesion or any lesion, we're able to read, to see the image, to see the lesion from 3 different planes, 3 different perspectives. So the question is this important? And the answer is yes, it is very important because it gives us more information. We're able to see areas of distortions much better. Now you can see here the field of view. It is 3 times larger with automated breast ultrasound compared to handheld ultrasound, and you can see here just with one scan the entire part of a small part, most of the breast has been scanned. Also, it is fascinating the post-processing capabilities that we have. You can see here slices on the transverse plane. Here are sagittal, and on the side here are coronal planes, just slices, just like cutting the bread through. It's different, just similar to tomosynthesis. This is very helpful. And we have a new sign, a new descriptor that we are, we are able to see with the coronal plane, which is called the retraction phenomenal sign. Just as with DBD, with tomo, we're able better to see stellate lesions, presence of any distortions of the normal breast parenchyma. So there is a great impact of the multiplanar reconstruction images because studies have shown that there is a downgrade, 3 to 18% of benign biopsy lesions, and also the specificity is increased and also the sensitivity for the detection of breast cancers. Now, double reading is possible. We do double read in our facility, and this is extremely helpful. And more precise comparison. This patient was to our facility a year and a half before. You can see just a little black dot that was missed. A year and few months later, she came in. You can see that it is just a little bit larger, irregular mass that has been developed. So precise location, not only of the lesion, but also more precise comparison with prior examinations. Now, with lack of radiologists, teleradiology has become much more, I would say, needed and familiar to all of us. So this is also a great tool for teleradiology. And AI now for ABUS is reality. So it is FDA approved in the USA from a few years ago. We have a lot of experience because we have been working with AI for ABUS for the past 7-8 years. And you can see how the image looks like. There is a dark dot, which is encircled with green. This is a suspicious finding. So by itself, it is able to detect, not characterize, but to detect suspicious lesions. And this is the correlates of the handheld breast ultrasound in this patient. So summarizing the pros and cons of ABUS, we do not have biopsy capability. Okay, we know this. There is a question about the area of the axilla. We have the possibility to scan. We have a special way of scanning the area of the axilla. Therefore, if the area of the axilla is included in the field of view, we are able to see in the field of view level 1 lymph nodes. The multiplanar imaging is in the large field of view one of the great advantages. We do not have vascularity, and the performance between ABUS and handheld is comparable. There are many studies have shown. Here you can see just a few of them. One of them is the study that we have published at European Radiology a few years back. So there is the incremental breast cancer detection between the two modalities, handheld and ABUS, is comparable, is the same. This is a very recent study that came out from Rush, from Chicago, that showed that ABUS utilization was very friendly use to women. They were very positive of using this new imaging modality. And in addition, and more importantly, ABUS exam, in addition to mammography, detected 2.5 additional cancers that were at an early stage. And most of these cancers were invasive carcinomas. So there is a great impact of ABUS in the early detection of breast cancer. And this is a study from China that has shown that the incremental breast cancer detection touched almost 4 cancers per 1,000 screens. And these are the results from the first trial for the BRAID, the first round of the BRAID study. We heard from Alexandra earlier the great results that were announced today, that were presented by Iris at ECR. And this is, this is very impressive because if we think how easy is ABUS to use, and especially without the use of IV contrast and without ionizing radiation, it is, I would say, a great, great success. And here I'm very proud to present our results from our study, where we included 7,493 screening examinations, and our detection rate were 3 cancers per 1,000 women that were screened. So ABUS detected additional 21 cancers that were not visualized on mammography, and most of these cancers were also not visualized on DBD. So undoubtedly, in women that have heterogeneously and also dense breast, supplemental screening is necessary. Also, we can see here that most of these cancers were invasive carcinomas. They were node negative, and there were most of them grade 2 and grade 3 cancers. Of course, in order to obtain such results, optimal ABUS image quality is necessary, so this requires correct use of the lotion, appropriate positioning, adjustment of depth, also appropriate compression and complete coverage. And this is where AI and the new premium ABUS plays a very important role. There are various other parameters that we need as physicians, just as other imaging modalities that we have been using. Besides assessing the quality that we receive from our technologists, we need to know precisely their patient's history to compare ABUS examinations with previous ones, also with mammography. If they should be done for me the same day. This is extremely, extremely helpful. This will improve our performance and reduce the false positive rate. So you can see from 8,000 examinations, the average examination reading, the average examination time was about 12 to 13 minutes, and we usually obtain 4 and not 3 views per breast. So we're talking about 8 views, 12 minutes. Our techs are very, very experienced, and the average reading time is approximately 3 to 4 minutes. There is a variation on the performance between our technologists. Our more advanced technologists have better performance. So we had a questionnaire that we evaluated every single examination. And by if it was acceptable, if it was good, if it was very good. So it is it is obviously the more experience the tech has, the better the image quality. No pain, almost every woman you can see here, 8,000 women, they all answer and reply positive to the fact that they would like to have an ABUS examination on their follow-up exam next year. Only 3 women did not want to have an ABUS examination. One was having some kind of medication that have a lot of anxiety. Another woman had a pacemaker. And the third, she had implants with liquid, not silicone. She was afraid that they would rupture. The compression that we apply is moderate to high in most of the patients. It is much, much better, much more effective to the image. And now the Invenia Premium ABUS houses AI features, which ensures and makes it much easier for our technologists. As we heard earlier from Alexandra, now the techs can check before they send the exam to the workstation that the entire breast volume has been captured. Also, it offers automatic nipple annotation. It reduces the scanning time by 30 to 40%, and there is, to my eyes, great improvement on image quality. And here on this slide, you can see the same patient, 2025, 2024. You can see the difference here on the transverse. It is exactly the same area where we focus more shadowing with the previous unit, much less shadowing, more, the special resolution I would say is much, and the better, and the image is much clearer, much more clear. And some illustrative cases, just 3 patients, 69-year-old, she did not have a family history. She had a fine aspiration in the left breast in 2003. She had a core biopsy in 2005. Her clinical examination was unremarkable. And now she came in. She has heterogeneously dense breast. And we found a very small mass irregularly. You can see it is located in the left breast. Just by clicking in the area of concern, we automatically obtain the location, area from the nipple, and area from the skin. It is also seen on the post-processing transverse images. These are the correlates of handheld, and also the biopsy showed an invasive lobular cancer, and this is the mammogram. This is the area. It was not obvious on the CC. There is something here suspicious, but with ABUS we felt very confident that this was a BI-RADS4 finding. And this is the correlate of the AI image. You can see it looks like a black hole. So every suspicious finding on AI, on QView cut, it appears dark. Our second patient is 70 years old. This was a screening mammogram. That was normal. That was performed at another center, not at our facility. She did not have a family or personal history, and clinical examination was unremarkable. This was not palpable. You can see it's a hypoechoic mass seen on all three views, and also it is very obvious on the right superior and also on the medial. So looking at a suspicious finding from different perspectives, we can get more information about the margins and the more about the descriptors of the lesion. These are the MRI images. And you can see we performed biopsy. This was an invasive lobular cancer measuring 11 millimeters. Sentinel node was negative. And a third patient, she has breast implants, and we're not sure, but we got stuck looking at an asymmetry located very near the right implant, just anteriorly and centrally located. It is a faint density. It is not seen on any other view. We perform a magnification view trying to see it and get more information about it, but ABUS was very helpful because we found a tiny lesion, hypoechoic lesion. You can see, though, although it is very tiny, you can see the retraction sign on the coronal plane, and you can see it's higher, it's taller than whiter. It is irregular, although it's very small. And this is the MRI correlate finding in the right breast. So this was an invasive lobular cancer, ER/PR negative, low KI, HER2 negative. So with this, I would like to close this presentation saying that mammography has begun through all these years. You know, he has given us, has saved thousands, hundreds of thousands lives, many women, but we have to accept that it does not perform equally to every woman. Women that have dense breasts do need supplemental screening. It is mandatory, it is necessary. And that premium ABUS, it is a new technology with the AI features. It provides better image quality, more confidence to our technologists. We feel more confident because the image quality is much better and it helps us with acquisitions. The scanning time is reduced. And also AI comes to fit here because it also helps to reduce the reading time and also to improve our workflow and efficiency. And shortly, very soon, within the next months, our book, An Automated Breast Ultrasound for Screening and Diagnosis, will be in the shelves. You'll be able to purchase it from Amazon and also from Elsevier. And with this, I would like to thank you, all of you, for joining us tonight. I know how important your time is during ECR, how busy you are, and I was really happy to see you, all of you here. Thank you so much.